So without further ado, Ken Benedict.
I was going to tell another story, but I'll leave it at that. I don't know if it was Steve's idea, but he said, wouldn't it be great? It's going to be in the afternoon. Everybody's going to be a little warm. It's going to be after lunch, and you're kind of getting a little sleepy. Why don't we liven things up by having a shill out there pass out or something? And I said, no, don't do that. Not in this situation, because it actually happened when we did it over at the Masonic, at Fort Mason, excuse me. And I was showing some particularly bloody pictures, and all of a sudden somebody just collapsed, had a seizure, and but that only lasted for a minute or so, and it's just because it was what's called a vasovagal spell, a simple faint. But everybody, and then we couldn't calm anybody down for another 15 minutes, and so on it went. I'm going to be talking about two things today. One is one that some of you have probably heard parts of. I try to modify it and change it, but it has to do with the surviving cold water immersion. And it's very important, particularly at the beginning of this race, when those first 3-4 days, you're out there and you really don't have the wind behind you so much, but you're sometimes sailing on a very, very close haul, and the boat has a lot of motion. If someone's going to be getting seasick, they're seasick. So the highest risk, in my experience, has been those first 3 or 4 days, getting out of the Golden Gate, getting into your routine, and then you cruise the rest of the way to Hawaii. But it's also during that time you run the highest risk of an accidental overboard. And then the other is you get very confident out there and somebody just makes a mistake and ends up, but the water's not so cold. And if you have an AIS or you have a PLB, you're very likely going to be able to rescue them. But those first 3 days, this is sort of really what I'm talking about. So let's get going. We have a very limited amount of time. I'm going to talk about the low-speed chase. Low-speed chase was a huge tragedy for the sailing community here in San Francisco. I was on the U.S. sailing team that reviewed the entire incident and published it and reported it officially, our conclusions to the U.S. Coast Guard. It was a horrible, in many ways, 6-7 months that we spent analyzing the low-speed chase incident. But we did learn an awful lot, and it's made a huge difference, I think, in some of the preparations in the Bay Area for sailing and racing. Just going to go through it very quickly. Capsize out at the Farallones, April 14th, 2012, at about 2:30 in the afternoon. You could see what the sea state was. It was not an atypical sea state for the Farallones. Some big swells, some big wind waves, and the water temperature is 51 degrees. It was 90 seconds from the time the boats capsized, the time that it was on the rocks. 90 seconds. There were 8 crew, there were only 3 survivors. All the 5 that died, all died in the water and all with PFDs on. U.S. Coast Guard helicopter was on scene within an hour, and the medical examiner, and I spent a lot of time with the medical examiners in both San Francisco and in San Mateo counties. The official cause of death was drowning. Not trauma, not other incidents, but just plain drowning. So Brian Chong, some of you may have heard him give speeches since that incident, gives the best narrative I've ever heard on someone who goes from an exciting and fun sailing situation to a true tragedy. I see another wave approaching, he said. It's massive. It's unlike anything I've ever seen outside of big wave surf videos. It begins to face up, its front flattening as it crests. By the time our boat meets it, there's no escape route. It breaks directly upon us. I lock my right arm into the bottom lifeline and brace for the impact. The last thing I see is the boat tipping toward vertical with a band of water still above it. A single thought races through my head. This is going to be bad. I was underwater until the boat righted itself. Confused and disoriented, I looked around while water cleared off the deck. Nick and I were the only ones still on the boat. The sails were shredded, the mast snapped, and every flotation device had been ripped off. A second wave then hit us from behind. This one ripped me off the boat and into the brake zone. I couldn't tell if I was in the water for a minute or an hour, but according to Nick, it was about 15 minutes. People have asked me if I swam for shore. The best way to describe the water in the brake zone is a washing machine filled with boulders. You don't really swim. The water took me where it wanted to take me. Drowning is the most immediate survival problem following water entry, period. If the victim of cold water immersion avoids drowning in the first few minutes, then the prevention of hypothermia becomes critical. These are the 4 challenges of cold water immersion. The first is what's called cold water shock, and I'll go into these very briefly individually. Swim failure, followed by hypothermia, and then possible rescue collapse. And I'll define that and talk about that. That'll be important for somebody, at least on every boat, to understand, particularly if you do rescue someone successfully from an overboard, some of the consequences of that being overboard need to be attended to. So cold water shock. This is defined as the involuntary gasp of air, whether or not your head is above water. It's triggered by cold water on the face and can last about a minute. It can last longer in slightly warmer water than 51 to 60 degrees. And when we're talking about cold water, in our case, we're talking 55 degrees and colder. Down below about 40, we're talking about frigid or freezing water, which also, all of this happens, but it happens in a much more rapid sequence. The sequence I'm talking about is really a cold water shock for a few minutes, and then about 15 minutes where you still can affect your own rescue. Talk a little bit about that. And then about an hour before hypothermia can start setting in. Lasts a minute, and there's a racing irregular pulse in most cases, and the blood pressure increases. Breathing, there's a reflex gasp and gagging, and this is what probably initiates the acute drowning episode, because you are underwater often when that gasp reflex hits, and you start inhaling water almost immediately. And then, if that doesn't happen, and your head is above water, and you've survived the gasp and gagging, then you have uncontrolled rapid breathing and inability to breath hold. Here is just a graph from one of the studies that shows what happens, and the little markers on the bottom of the graph are 5-minute increments. The marker at the very front is 5 minutes before the individuals were in the water, and this was studied on females and males as well. And you find that gasp occurs right at the beginning with that very high frequency breathing, and then it slowly comes back to normal over a period of 15 minutes or so, a little longer in warmer water. The body's initial response to cold water immersion with the heart rate going up, heart rhythms, this may be the explanation for some of the rescues that we've actually had on the bay here, where somebody has gone overboard and the boat does everything it should. You do your turn, you get back, you get them back on the boat, or potentially back on the boat within 5 minutes, maybe 10 minutes at the most, and they're dead. They're dead now. We suspect that the main problem here was usually a fatal cardiac arrhythmia when they hit the cold water. And hitting the cold water puts a tremendous strain on the heart, and if there's any possible myocardial damage previous to this incident, this can be the consequence with a sudden cardiac arrest. Finally, the brain. As you're in the water longer and you're starting to get cold, you get reduced blood flow, you start getting confusion, disoriented, and you eventually can lose consciousness. So the second thing after the cold water shock is just swim failure. And the difficulty here is that you continue to have rapid breathing. You can't time the breaths with immersions. You lose coordination, you lose strength, you lose judgment. And this makes it very difficult to self-rescue. The third is hypothermia. We'll spend a little bit on hypothermia, but the two first issues are the ones that I really want to point out, is that you have that first 15, 20 minutes of rescue time that you can actually save someone's life. The hypothermia varies so much between individuals that it can start within 30, 40 minutes, again, dependent on the water, sea state, depending on your body build, et cetera, or not really get serious for hours. But hypothermia will occur, and hypothermia will occur even in warm water. If you're in water that's 70 degrees or so, you can still get hypothermia. 80 degrees, eventually, if it takes a long rescue period of time, you will get hypothermia. Body loss in the unclothed swimmer, and these were volunteers from the Navy, and we did similar kinds of, how we say, not quite volunteers, but with the training ship. Here, yeah, you know. Here at 82 and 75 degree water, and you may very well be in water this year especially, that could be up to 80 degrees out there on the trip to Hawaii. 75 certainly at times. You have a much longer chance of surviving and not getting serious hypothermia. You can just see the way that graph goes, and this can extend out quite a ways. However, it seems to be the break around 71 degrees, where the body definitely gets colder, faster, and you can see 71 degrees down to 61 degrees, and they just keep getting worse. So just to keep you appraised of that, what we term is body temperature, by the way, and hypothermia is a core temperature. That's this temperature right inside the center of the body where the critical organs are. But we have thermal shells. We have skin, and we have subcutaneous fat, and then we have muscles, and that all protects the core. So guys that are thick, ex-wrestlers, guys that lift weights, some fat guys that just hang out on the couch actually have a better survival rate than guys like me, tall and skinny, and I have run most of my life, and I would die. I'd be the first one to die out there. And so this is why this is an important topic to me. Is look at shivering. Shivering is probably the best indication that you have mild hypothermia. Shivering is good. It increases the metabolic rate of the body. It creates heat and is a very protective device. It hurts, though. It's very painful and it's very uncomfortable, but it is a good sign, and it usually means, almost always means, that you have mild. There is beginning, though, a lack of coordination, some reduced grip strength, some stumbling, but you're still alert, and the victim at this point can certainly help in the self-rescue. This is someone perhaps that by simply grabbing a hold of them with a line, throwing a line around them and get them back on the boat, they can help you do this. Beyond mild hypothermic, forget it. This is going to be dead weight. You're not going to be able to get this person. They might not even be able to follow your directions. So let's go to the treatment if you get them on board. Strip the wet clothes, remove from the cold environment, very obvious. Wrap in fleece, sleeping bag, dry insulating clothes. Shivering, like I said, is a good rewarming technique. You can give to the mild hypothermic some warm, non-alcoholic drinks. Make sure there's some sugar content, because that is actually more important than the temperature of the water because they're using up their glucose supply, their stores, very quickly. Mild heat to the armpits, side of the chest, but make sure it's mild. Usually have a towel between the actual heat device, like one of these pads you can break, because hypothermic skin is damaged skin and can end up with burns. Gentle exercise, mainly something like just sitting and then just moving your arms, can generate body heat. I generally don't recommend that, but it is officially recommended by some people. Moderate hypothermia. Now we're talking about a true beginning of life-threatening situation. The shivering has stopped. There's deteriorating coordination. They're now confused, unable to follow directions, getting dopey. The victim will not be able to self-recover. This is important. They will not be able to follow directions. This is important to know. The temperature will also continue to drop in these patients once you get them on board. And it's a phenomenon called after drop. I won't go into the mechanism of it, but it's something to remember when we get to the rescue and care on board boat when they get back. And they will be lapsing into unconsciousness. This victim requires more observation, one-to-one care. You assign somebody on the boat to absolutely have no other job but be with this person until either they have recovered from this or you've transferred this person to a higher level of care. Rough treatment is to be avoided. Even with mild hypothermia, it can produce dysrhythmias of the heart, and there is a very strong possibility as the temperature is dropping to this level, and certainly to the severe level in a moment or so, they can get ventricular tachycardia, they can go into ventricular fibrillation and have a sudden cardiac arrest with rough handling. Give only fluids if conscious. I generally don't recommend much in the way of fluids for somebody with mild. Rewarm with heat to the torso, the neck. Do not apply heat to the limbs. Do not immerse in a shower. Consider that this is a good time to use the buddy heat by somebody stripping down shorts, t-shirt, or whatever, and lying next to the hypothermic person, and then covering both with fleece and so forth. The way you lie down is side to side. This is where the body has the least amount of muscle and fat, and so you get more transfer of heat from the body by doing it that way. And continue doing that when either the helper, the buddy, starts shivering him or herself, or you just need to keep somebody going for a long period of time. It's almost like CPR, where you just change rescuers periodically. And for these cases, absolutely seek medical attention from the beginning if you can, but even if they recover. This person is most likely going to need some significant medical help once they are off your boat. Severe hypothermia is really on a small boat, and under the circumstances you're going to be sailing, probably deadly. This person probably will not survive, and I just want to say that to you because there have been attempts in situations, and the crew feel really guilty. What could they have done? I'll tell you what you can do, but I'll tell you the success rate would probably be very small for really severe hypothermia. By this time, muscle rigidity has come into play. Patient is unconscious. Your victim appears dead, unconscious, cold, maybe a pulse, very slow, hard to detect, and I emphasize that it would be very hard to detect. So you take the pulse for at least a minute. You have to get on the radio and start working with advice to talk you through this and help you through this process. It's really significant. You handle your victim very gently. Keep them horizontal, which is almost impossible when recovering someone from the water. Monitor the victim. The victim may just be alert enough to be fighting you off. If breathing and a beating heart, even so slowly, do not perform CPR. It's far better to have a heart rate in this cold of a patient at maybe 4 to 5, 6 times a minute than starting CPR, which will have a high incidence of ventricular fibrillation and probably sudden cardiac arrest. Maintain the airway. This is very important, and you can do that by just simple CPR stuff that you learn in a first aid course. And put in, don't give up the stiff, and do not presume death until the old warm and dead, but again, that could be very difficult to ascertain on the boat. So, what can you do, and what do we know about survival factors? The ability to swim, the ability to keep the head out of water are all positive. Ability to avoid panic, sea state. The sea state, for example, in the low-speed chase, was horrible. They were in shallow breaking water. I mean, that's as bad as it gets, but it doesn't get any better sometimes in the conditions that people fall overboard on the open ocean as well. The availability and type of PFD is increasingly evident that this makes a huge difference. And we will talk later. Denny's going to talk about PFDs, I'm sure. I'll mention a couple right now when we get to that. But the availability of a life raft, throw that in the water with line on it, of course, and you can actually send a rescuer from the boat in this situation, potentially safely, to do a hand rescue to the life raft. I don't generally recommend a second person to get in the water when somebody has gone overboard, because too often now you have 2 people in the water that need to be rescued. Don't do it. Availability of other floating objects, and as you know, you try to throw whatever you can into the water as soon as someone goes overboard. You have someone watch the person. You have the helmsman be given directions, always pointing to where the person is, et cetera, et cetera. All that stuff that is just basic seamanship that is more seamanship than medical. Water temperature, we've talked about cold water, more deadly than warm. Physical characteristics, talked about that. Type of protective clothing, Mary's was right on. You wear that kind of clothing, you're going to have a better chance of surviving when you go in the water. Not only avoiding hypothermia and wind problems on board, but in the water. The behavior of the victim in the water. We talked about not panicking, but keeping a clear head. That isn't always possible. The availability of signaling and communication. This has revolutionized our ability to actually find a person in the water after they've gone overboard with the PLBs and possibly the AISs, which are kind of expensive, $300, $400, $250, I think, for some of the cheaper ones. The proximity of rescue personnel. You saw in the low-speed chase, Coast Guard was there within an hour. They were there within an hour, but everybody who was going to die had already died. That was what happened there. So PFD factors. Any type is better than none. And so this is something you really, my recommendation, anytime you're out at the open ocean, have on a PFD. Just make it part of your lifestyle. The Solus is awkward, type 1, big old bulky thing that is still the main recommendation, although the Coast Guard, I think, is getting sensible about small boats anyway to be able to accept the inflatables. The inflatables now have gotten so good that that's really the only kind of life jacket, PFD, that I would recommend for open ocean. And Denny, you might, I don't know if you confirm that or not, but I really think so. Certainly Chuck Hawley and I pretty much are on the same page with that. What does it do? How does it save someone's life in an overboard situation? Well, number one, it brings the victim back to the surface as fast as it can possibly do and provides enough buoyancy so you bob to the surface quickly. Maybe you won't have that gasp reflex underwater, but it will bring you above water so that gasp happens there. And when it happens there, you have a much less likelihood of drowning immediately. And will keep your head above water if it's well designed, even if unconscious. Hypothermia reduction. It isolates high heat loss areas out of the water, which are the face and the top of the head. which are huge heat loss areas, especially in a child. I could go on and on about kids and all this, but I won't today, but kids have very special needs for this. Buoyancy also allows you to assume the well-known help or huddle postures. The huddle is important. I'll just say one more thing about a kid. Kid goes in the water. This may be the one time, if you're able to do it, to have someone else in the water with the kid. And I say that with tons of reservations, but I don't know if I were the parent and my kid went in the water, you could keep me on the boat. Someone would have a line attached to me. I'd have probably grab another couple of floats and get in there. But the huddle position is, if, say, you had a tragedy, the whole boat goes in the water. This is what you do. You grab each other, you hold each other in a group, and that can reportedly increase survival by 50%. Also, PFDs allow you to orient yourself to the waves so you don't have to time your breaths so much. So you can get your head to the back of your head to the waves and not facing them. And there's a thing called the heave period that is it should be noted now on almost all the new PFDs. It is the time it takes to get back to the surface after immersion. So every time you get dunked in your wave, how quickly that PFD can bring your face back out of the water. So the shorter that heave period, the better it is. Signaling devices, won't go into much detail on this, but the best signaling device you can afford, personal, PLBs, AISs, whistles, lights, reflective tape, absolutely mandatory. And then also at the same time, think of the vessel itself, signaling from the vessel to other vessels nearby or on the standard Coast Guard channel, and say exactly, even though you think not much is going to happen, you're probably in control, let other people know ASAP. And if you are in another boat and you get these signals, follow radio protocol. This was a huge problem in the LSC incident. We had other boats, lots of them, stepping all over the distress signals that were being sent by the LSC when they, during the early part of getting on the island. Nick went back out to the boat on the rocks and was able to use the radio. And there were a number of vessels that contacted them and said, well, where are you? What's going on? And they were stepping all over themselves, so there was hardly any message that wasn't garbled in the process. Prevention of cardiac arrest, stabilization of core temperature, and transportation to definitive care. These are the three major principles in the care of the patient at this stage when you have somebody that's definitely going to have to leave the boat. Okay, avoid rescue collapse. And this is what you guys do to help someone. Again, talk about retrieval of the victim, horizontal, carefully as much as you can, avoiding the heart problems. Beware of sudden drop in blood pressure. That occurs almost always, and it has to do with the physiology of the body. You're in a high-pressure system, even if you're at the surface of the water, and they've already had some diuresis, they've urinated, they've lost some fluids, so there's a very good chance you can get a drop of blood pressure as soon as they're on the deck of the boat. Maintain the horizontal positioning, minimize physical activity, again minimizing this temperature after drop phenomenon, and again handle gently, kind of repeating myself. What do you do about CPR? Well, first of all, take vitals for at least 1 minute in the very hypothermic victims. And you do CPR by the, quote, old method, breathing first. This is the one exception to what we're doing almost all in pre-hospital care and hospital care now, is to start these rapid compressions, 100 a minute, without any breaths. In this situation, you're assuming that this person was healthy, had plenty of oxygen, and actually not having enough oxygen, but having a solid heart that can keep beating. And so you give them oxygen as soon as they come aboard, as soon as you can. 5 breaths, 30 compressions, follow 2 breaths, 30 compressions per minute, and then until warm. And that's every 30 seconds. And evaluate in all these cases for trauma. Look for trauma. Very likely that the reason they went in the water is they got maybe hit by something, or they tripped and injured themselves. So the final other things, avoid further heat loss by keeping you warm. Minimize conductive, convective losses, again, by wrapping in clothes. Remove clothing carefully, dry, protect with insulation. Active rewarming in the field is probably unlikely unless you have somebody that can start IVs and can give warm fluids if necessary. Use your radio and sat phone as soon as possible. Give your position by GPS if you can do that immediately, and do prepare to transfer to another vessel or helicopter. In conclusion, stay out of cold water. So, Mary, right? And then act early when symptoms are present. Dress effectively for the environment. Wear high buoyancy life jacket to maintain an airway. Understand the treatment of hypothermia. Brian Chong gave a speech on 1 year after the LSC tragedy, and he had been giving safety talks most of that year. This is the summation of what his thoughts were 1 year later, being one of the 3 survivors. He said, on this anniversary, as we remember those we lost at the Farallons, let's also keep in mind that this is our moment to cement a culture of safety by continuing to invest in training and equipment that will save lives. And I really appreciate the work that Steve, the work that the whole PAC Cup committee has done to dedicate this half of a day to just medical issues. This is one of the things that came out of our report that needs to be done more of and needs to be done more often. And by the way, this is being tape recorded. It will be on, I believe, on the website occasionally, soon.
It will be on the website.
Oh, good. And also, all of us have prepared papers and documents that supplement our talks. So you can go back and actually see these. I believe all of our PowerPoints will end up on the website as well. So you don't have to be scribbling too many notes. Just be here and realize that you can go home and be able to see this stuff at your leisure. So let's see how we're doing on time. Doing okay. The second half of my talk has to do with illness called illness and injury at sea. And today I'm going to be focusing a lot on a study that was done and published in the British Medical Journal of Sports Medicine back in 2002, and it had to do with a around-the-world race with 2 of the 6 legs being in the southern oceans and the other 4 touching land, and it was an interesting study. And like the Brits, it was totally obsessive-compulsive and very, very data-driven. And for a doc, it's great to read that stuff because I love anecdotes, but when I can start sort of sinking my teeth into real, what appears to be a good study in numbers. But let me start with the world as it was when I got involved in my first ocean race, which was the Transpac of 1967. I was going to be on the boat, Bluebell, the one that's mentioned, and you can't see it in the article, but was on the front page of the sports section of the LA Times. My classmate and I tossed a coin because we had been offered the job of one of us to be on the boat as the medic, and the other one to have the wonderful opportunity to bring the boat back to LA. Of course, my friend won the bet by being able to be on Bluebell during this race. 1,200 miles into the race, the owner-skipper, Morgan Pattison, had to be evacuated from the boat. He had had excruciating abdominal pain. He had locked himself, gone kind of crazy. He locked himself in his cabin, had to have the lock broken. My Roger Wheelis, my friend, we were both third-year medical students, so which means we really did not know anything. Truly, it's worse than not knowing anything because we're just full of ourselves. So, excuse the language, but that's what we were. Roger became sobered up very quickly. He went in, and even he, like most of us by that year, was able to detect that his skipper had what's called a rigid abdomen. It was like a board. And found out that he had stashed away, I don't know how many cartons of the Camels that he was constantly smoking in the, behind the cockpit. And also he had stashed away an entire box of Maalox. This guy, in retrospect, had had a history of major ulcer disease, had most likely perforated an ulcer, and now had full-blown peritonitis. And they were 1,200 miles out of LA, about another 1,200 miles to Honolulu. So they were able to evacuate him. They actually made a rendezvous with a submarine tender the Navy loaned, basically, to the Transpac to take him back to San Diego. But 48 hours later, now with a very demoralized crew and some bad weather, the second in command, Kirk Thomas, was hit by a backstay lever, which is exactly that lever, because I took a picture of it as soon as I got on board in Honolulu. What they had done, it had an accidental jibe. The backstays, one of the backstays started to fail. They threw the lever down too soon. It bounced back off the deck, and that's the size of a baseball bat, a solid steel, and just hit him and pretty much opened up the left side of his face. So with the help of a couple of docs on other boats, my friend Roger did know how to suture. And so over a couple of hours, these guys were able to give him directions and give him guidance. And he actually sutured Kirk up, and he made it all the way to Honolulu. And the boat kept racing. However, before the boat even reached Honolulu, they got word from the hospital in Santa Monica that their skipper had died. He died 2 days after getting ashore. And in those days, that probably wasn't that unusual. And I remember that could have easily been a death sentence anyway, even on land. This was Bluebell. I went out with the press crew so I could take pictures and meet with the guys immediately and kind of offer whatever support I could offer them. But that's the demoralized and very, very, very upset crew of the Bluebell at the end of that Transpac. I only mention this in that because these races are fun. They're safe. There's a high incidence of nothing happening. Very low incidence of something happening. But when it does, it can be like this. So looking at this study, get a little bit of an idea. This is of 365 amateur sailors on 14 identical vessels, which were the 67 Challenger, 67-foot solid steel boats sailing around the world. Other studies and other reports for other transoceanic races and stuff, they were very much in line. But this, for me, sort of sealed the case that pretty much the statistics I'm going to give you today are probably pretty true for almost any ocean race, even what should be a very nice and uncomplicated race to Hawaii. So there were 685 cases of illness or injuries, split about 300 injuries and 286 cases of illnesses, so it was 44%, 56%. 3 illness evacuations by sea by the Royal Navy. The Royal Navy does do a lot of support of the British, the big British races. So their shoreside support for that race was very much pioneering, not really at that point, it was pretty well known what you do, but they had full telecommunications with every one of the boats and had already seen a lot of the participants and done the physicals themselves. But they had 3 evacuations, 2 to the Falkland Islands and 1 to St. Helena. There were no deaths on this race. So what did they have on each boat? They had 1 volunteer medic supported by some qualified onboard or offshore medical officers. Who were those? Well, sometimes it was a Navy physician on board with the medic. Sometimes it was another medic that had a lot of experience. In any case, they really got on board and, again, onshore, really good medical support for every one of these boats. And I think this is exactly the direction you're heading here, Steve. You guys this year are going to have a potential for having one of the safest yet best protected, best support on the medical side that you've ever had in a race. And again, I think this is very cool. So you use your Inmarsat satellite phone, fax, SSB radio, that's what they used. And again, I said the Royal Naval Hospital in the UK, fax and telemedicine. These are what the capabilities of their onboard medics were. They were able to start and manage IV lines, administer IV intramuscular drugs, administer IV fluids, and they could suture. They could also insert, for God's sake, chest tubes, splint and cast limbs, strap joints, and have ALS skills. These are not your ordinary medics. These are more like my friend John Tausig, who came up from Santa Cruz with me today, who is a flight paramedic on helicopters, and he's fabulous background and one hell of a smart guy, but he's also got the hands-on training. Well, not so smart, but because he came with me today, he could have been with his lovely girlfriend. I talked him into it. But this is the kind of person you're ideally going to have on board. And not a has-been ER doc who has not been in the ER now since my retirement a year and a half ago. Already my skills are shot, but the onboard paramedic, who does this every day is going to be a greater asset to you than the best board-certified doc who hasn't seen a patient in 3 or 4 years out there. Anyway, we used to have psychiatrists come on board. Yeah, I'll take care of you. Guy just broke his leg. Therapy session. Everybody has to get feeling good, and then we'll take care of the leg. So subtypes of injuries, as reported, these were 299 injuries. The largest group were abrasions and contusions, which are basically scrapes, bruises. Not bad. Very easy to manage. Every one of your boats should manage this on board without any problems. Supportive dressing, sometimes maybe with topical antibiotics, whatever. Cleaning, keeping them clean. We'll talk a little more about hygiene, but hygiene is one of the biggest problems on a boat, and that's the biggest source of infections, certainly in exterior parts of the body. So that was 30. That was a third of them more. Burns, next big category. And they included in their group thermal burns, rope burns, and sunburn in this part of it. Again, supportive dressing, NSAIDs, which are your Advil, ibuprofen, etc. And that was about all they really needed to do, and they got good results. And again, they managed all of these on the boat. Now we get to a little more complicated stuff that it's a little hard to manage all of these kinds of injuries, which are fractures. And there were 11% of the sailors on these boats had fractures. As a subtype, though, it seemed that they had more of these injuries again in the southern seas where there was a lot of boat motion. But nevertheless, it's a significant amount, and you can't discount it, I don't think. On board, again, they had medics who could splint, cast, reduce simple fractures like what are called Colles fractures of the wrist, so forth. Ankle fractures that are not terribly bad, but I didn't see one that I didn't see in their reporting the kinds of ankle fractures where we almost immediately have to reduce them. Even ER docs do it all the time while we're waiting for the orthopod. But they take care of that. They use tramadol, which I think is a horrible medication, but that's just my opinion. It's got everything bad in it. It's got selective uptake inhibitors like Prozac-type medicines mixed in with opioids, and it's still a Category 4 in the United States, and so it's not considered dangerous, but it just, anyway, I won't go into what I would use, but I'm still a big proponent, at least for these kinds of situations, to have some just clean opioid on board if you can get it. And that's another issue. We're sort of an opioid witch hunt right now, so I have to deal with that. Lacerations, 11%. Now, most of these were sutured because of their wet-cold conditions, they said, but I think they were sutured because they could suture. They had resources on board, and that's probably the ideal treatment for these. But you can do an awful lot with steri-strips and super glue or dermabond. That's the medical name for the stuff we use. And if you do it right, you can actually manage a lot of superficial suture, lacerations that way. Suturing also was noted in this study to be very difficult at sea, simply because of the motion of the boat, and very difficult sometimes to just do a clean job. In any case, they suggested using stapling devices in the future for those long-distance races. I don't know. Maybe yes, maybe no, but you got to be trained in doing that too. It's not just something, like you have on your desk. Okay. Then we get down to final cartilage and ligament tendon damage. This was common enough, and these you can take care of on the vessel. And use things like SAM splints, which I love. I love SAM splints. You going to mention that, Denny, at all? They're just one of my favorite things. They just work. Here we're looking at an ankle, and that's where they were, primarily ligament sprains on ankles. And then finally, the old head injuries. Interestingly, they had 7% head injuries. Not a single case was recorded anyway in the report of loss of consciousness. That blows me away. It's almost hard to believe, but they didn't. So I have not devoted a lot of time to talking about the patient that's totally unconscious and has probably got a subdural hematoma and is going to die on you, because I'll spend your time on other things. Okay, anatomical region of the body, where did they happen? They happened on the wrist and hand, the head and face, the neck and back and the ribs. The upper half of the body seems to take a beating out there. It really does. And then you get down to your knee, the thigh, and the ankle and the leg, and then finally shoulder, clavicle. Shoulder dislocations are not unusual in anybody on board a boat. Good, thank you. That anybody on board the boat that's had a history of shoulder dislocations. If you ever had one shoulder dislocation, no matter how well it was repaired or actually self-repaired, you are at a higher risk of having another shoulder dislocation. The only good side of it is it's a hell of a lot easier to reduce. The second and the third, and if you're really out of luck, you're going to be reducing it every day until you get to Honolulu, which I have done on the training ship a couple of times, where I just had a morning scheduled repeat reduction because the guy never wore his sling. He took off the strapping I gave the only strapping I probably would have put him in 4 points and keep him in his bunk. But okay, now illnesses. Illnesses are interesting because there were more illnesses than injuries. And what was the big one? Gastrointestinal, abdominal pain, and some urinary stuff. No surprise for anybody that's, John and I were talking a little bit about that in wilderness medicine. Gastrointestinal problems are probably the #1 issue out there when you're on the ground, on the land. They tend to be a little more difficult at sea because it gets confused with seasickness, and it may be precipitated by the dehydration, change of habit, nutrition, a lot of things, but pretty high. That group are the ones that required the evacuations from the boat. And there was one case of bloody urine, Not sure why, but oh well. That was scaring everybody, I think. Okay, a case of acute GI bleeding, yes, that's sort of in the same family as the guy they had to take off Bluebell, and a case of suspected appendicitis. By the way, there are some medical treatments that can buy you time on appendicitis, and maybe you could mention whether you're would be able to advise if they had the right antibiotics on board for the management of appendicitis at sea without doing an operation. And the success rate with the right combination of meds and other treatment, people can do quite well for a few days with truly documented acute appendicitis. Okay, gastroenteritis, one boat was totally incapacitated by probably a norovirus. The entire crew had diarrhea and vomiting. It was awful. Skin, not including sunburn, boils. The British call it gunnel bottom. You call it what? Baboon bottom. Right, but it's the same thing, and it's just because you're sitting in a wet environment, and it is awful. It's really bad. If you've never had it, you haven't sailed long enough in one position, day after day, especially in warm weather, which you'll be in. Okay, treatment, again, improved hygiene, often lacking oral antibiotics, etc. Respiratory, flu symptoms, not uncommon, middle ear infections, decongestants, cough suppressants. Again, you can probably do well with some oral antibiotics. Seasickness, 16%. Definitely the authors of the study feel it's underreported, because often with seasickness, there can be another medical problem or a surgical or a trauma problem, and seasickness is not included in there. And they used a lot of antiemetics, and they felt most of them were minimally effective, but we've talked about that. When it happens, wonder what circumstances. Very often happens when there's equipment failure. Obviously, rough weather can precipitate these both illnesses and injuries. Sleep deprivation and fatigue with lack of judgment. Robert Redford here is doing just a great job, except for one problem with his safety harness and the line. What is it? He's hooked onto a lifeline, for God's sakes. That's not the place you put it. You put it towards the center of the boat on something solid, so if you do go overboard, you're only right there at the edge of the boat, not 6 feet down, and also hanging on a lifeline that may not support you. Anyway, I love this shot. There are other. Seasickness, of course, it's the great precipitator of all sorts of nasty things out there. So what do you have on board? You have a good medical guide. This is my favorite, The Marine Medicine by Jacobs and Weiss, both of whom are friends of mine, and they're good docs. And this is very small. It's not expensive. It's terrific. I've used others. I've used a lot, and there are others out there. But this is my number one. A good medical kit, which Denny will be talking about soon. A good onboard medic. Here's Florence. I mean, who could be better than Florence Nightingale on board your boat? And a good communication equipment. How about a terrific onshore telemedicine consult? Yay. So, conclusions. Trauma and medical problems are relatively common in amateur long-distance ocean races. Most can be managed at sea, provided optimal communications, provided good training, and provided good equipment are provided and maintained. And just when you thought you had everything under control, this, in my number one medical journal, the Journal of the National Enquirer, this is true. And I want you to know that, so be prepared. And whatever you do, make sure at least one person on board has connections with the outer galaxies. That will help you a lot. Thank you.